Yes. Hi, everybody. Welcome to Community Conversations. Thanks for coming. I have a couple of announcements before we get going today. The first is that there is no Community Conversations presentation next week. The campus is closed for Thanksgiving. We will not be here, so you should not be here. So just keep that in mind. But we will be back the week after. So that is December 2nd, I believe, and that will be our last of the series for the quarter. We'll be back again in January. Don't worry. Check out the website. We'll be updating that when we get our schedule hammered out for winter quarter. But on December 2nd, I was able to sweet talk Michael Strayer out of retirement to come in and give a talk about the teen brain. So please join us for that as well. But today, I'm very glad to welcome Karen Joyner as our speaker. Karen Joyner is the Executive Dean of Instructional Programs here at LCC. She's been at the college for 36 years. And before that, she actually received her associates from LCC before going on and finishing her nursing education. She's the former head of the nursing program. She has worked in hospice for 2 years. And so she brings not only knowledge of the generalized nursing approach to this, but also specific experience and knowledge of how hospice and end-of-life care works. So please welcome Karen Joyner.
Thank you, Courtney. So I'm glad to see everybody here today. And it's fun to talk to a lot of nursing students as well as everybody else in the audience and some nursing faculty. So it's good to see you all. So as Courtney mentioned, okay, who I am, right? I'm currently Executive Dean of Instructional Programs here at LCC. And right now, my portfolio is science, technology, engineering, math, PE, and education. It was previously nursing and healthcare, and it was really hard to give up the nursing, but I'm very excited to have Mary Bond as the nursing program director now. I am working towards retirement, hence Mary is part of my wonderful succession plan. So my journey, as Courtney mentioned, I started here at LCC as a nursing student. And interestingly, what brought me into nursing was I wanted to birth babies. Man, that's what drew me into nursing. I had a good friend who was a labor and delivery nurse, and she would tell me fascinating stories, and I just thought that was wonderful. Well, so I came to LCC with that in mind. Not at all where I ended up, okay? Never have worked in labor and delivery. So my journey took me different places than where I thought it would, as life usually does for us anyway. From getting my LCC, my RN at LCC, I went right into nursing education and cut my teeth in teaching nursing assistants, did that part-time. And while I worked part-time there, I also worked part-time in long-term care settings, did a couple years in hospice care, did some home health nursing, and kind of a variety of other things, but my love was teaching. So I went on to get my bachelor's degree and then my master's degree. And I decided when I got my master's degree, I would do it in adult health. And that way, with a minor in nursing education, that way it kept more doors open for me. So I could then work as a nurse practitioner and teach. So that is what I have done for most of my career. Started teaching nursing, like I say, part-time in '85, went full-time in about '93. I did that, taught fundamentals, which I love. Nursing fundamentals taught in almost every quarter of the nursing program at some time or another. So then after that, became the director of the program and dean, and that's where I am today. I have maintained a clinical practice as a nurse practitioner until just recently. I have retired from that job, but still have my LCC job. So that's kind of what gives me the qualifications for this topic, is both having taught it for many years and having worked it for many years, plus just life experience alone. You know, I've gone through family members with end-of-life issues, and it's just always been a fondness for me. When I look back over my nursing career, my first love was teaching. Always will love being a nursing instructor, but also near and dear to my heart was my time at hospice. And that was my favorite unit that I taught in fundamentals, was the hospice and end of life issues. So, okay, I'm going to try this special little. Aha, there you go. So today's talk, okay, the little bywords were, what are the choices when cure is no longer likely? And how do I ensure comfort for myself or my loved ones? And palliative and hospice care similarities and differences are going to be shared in this session. So I wrote some objectives, as any good teacher does, right? So our objectives today are, first of all, to examine some selected universal truths. And then I'd like us to go through comparing and contrasting hospice and palliative care, listing eligibility for hospice care, dispel some common myths, because there's plenty of them out there, examine grief. And we can't look at end of life issues without looking at grief. And then my final objective is to develop hope and empowerment about making care and comfort decisions for yourself and loved ones. Oops, excuse me. Okay, so I thought I needed to start with some selected universal truths. Now, I've taken a lot of liberty here, right? I have labeled these as universal truths because in my experience, they are. And so we could debate whether they are or not, okay? But we're going to go with, since I'm up here speaking, I get to choose these. So first of all, we will all die. Now, this is debatable now with current technology, right? With cryogenics and our freezing of bodies and mind and DNA, maybe we won't all die. But right now, for the majority of us, it is a universal truth that we will all die. Okay? And a second universal truth is that life is not fair or equal for everybody. It just isn't. We cannot say it's fair. Okay? Now, why is it fair that I'm blue-eyed, blonde, and 5'7"? That just is, right? Is it fair that I've had breast cancer and someone else hasn't? No, it's not fair. That's just life. Okay. So there is not anything that says we are all going to get the same life experience and have the same health challenges or no health challenges. And we just have to accept that. And I'll kind of tell you why these are my important universal truths at the end of this. Aging means change. From the moment we're born, we start aging, right? And that means change. It's not good or bad. Okay, if we take all the value statements out of that, it just is. And as we get older, we notice the change even more. Okay? And back to the other universal truth, life's not fair, nor is it equal, and we all age differently. Okay? So the fourth one is stuff happens. Okay. And stuff, that's a great broad catch-all term. Okay, it's kind of like germ. Germ is a great medical catch-all term. Okay, what is a germ? Okay, that's debatable. So stuff happens, all kinds of stuff, and it affects us. COVID happens, and it affects us. Grief happens, and it affects us. We stumble and fall and hurt ourselves. That affects us. So stuff that is within our control and without of our control happens, and we don't always know why. So I'll tell you why I'm discussing these. And it is because when I was a nursing student in my first quarter of the program, just like we still do, we spent our clinicals in long-term care. I'd never been exposed to long-term care, didn't know a thing about it until I went there as a student. And I went home every day and cried. It depressed the heck out of me. I thought, I don't like this. This just depresses me. And I had to struggle with that for almost the whole quarter until finally one day, for whatever reason, I realized that there are these universal truths. Life's not fair. Okay? Aging isn't fair. Being in a long-term care facility isn't fair. Okay? And yes, it can be sad. Yes, it can be depressing, but it's a universal truth. So I was at a point where I had to make a choice for myself. Do I want to sit and be depressed and stuck in this hole of depression about this because I can't change it? Or do I accept that this is a universal truth? And I go forward then thinking, all right, given this truth, what do I do with it? How do I make it better? How do I make it acceptable for me? How do I take joy in what I am doing in long-term care? And that's where the difference was. So though I accepted that it was not fair that one of my favorite patients who could not speak to me because she had had a stroke, but I just adored her, okay, and she and I had a relationship, I was able to take that from being depressed about the situation to finding joy in my ability to connect with her and to give her a little bit of quality of life when I was around, and to ensure that she had some quality of life when I was there. Couldn't control any more than that. So that's why I present these to you today, because I think it's really crucial to being able to look objectively at end-of-life care issues. So I guess we have to accept it before we can do anything else with it or about it. So then, given those universal truths, what are healthcare options when an illness, condition, or disease is prolonged, or if cure may not be likely? Okay. And even if cure is likely, but it might be out there ways, what do we do in the meantime? All right, so I thought, okay, and these are my limited choices, right? You might think of others, but number one, we can do everything possible and hope for improvement or cure, right? And that's okay. I want to tell you that none of these choices are right or wrong. There's no judgment. There's no inherent moral value with these choices. We assign them our own personal moral value. We assign them right or wrong. Okay? But the choices themselves are neutral. Okay? So another choice would be to say, nope, don't want any treatment. Nuh-uh. I just want to let nature run its course. Or I want just a little treatment. I'm going to select from a menu of treatments what I want and don't want. That's okay too, right? And we as a nation believe so strongly in personal autonomy that that's very much a choice. Okay? People should have that right to decide what they want to do, whether it's full treatment or no treatment. They also could choose assisted suicide. This is legal, right? And this is a whole nother topic. Okay, so I won't get into that one today, but it is a choice. Okay, and if you want to know, I will give you my opinion about assisted suicide, but that means I'm going to attach some morals and values along with it. Okay, so palliative care is an option. Hospice care are options. Okay, that's a great segue then into, well, what are hospice care and palliative care, and what's the difference? So those are the two options that we're going to talk about today. So, oops. All right, I got my pages all flipped. Okay, so definition of palliative care, and it is pronounced palliative. Okay, some will say palliative. It's not wrong, it's just different, tomato, tomato, okay? But palliative. So it's compassionate comfort care that provides relief from the symptoms and physical and mental stress of a serious illness or life-limiting illness. It can be pursued at the diagnosis, okay, of the illness or problem. It can be done during curative treatment and follow-up, and at the end of life. So it doesn't have a definite, you must begin it here. It can be started at all times, okay? So what is it? It's specialized medical care for people living with a serious illness, such as cancer or heart failure. Patients in palliative care may receive medical care for their symptoms, along with treatment intended to cure their serious illness. Okay? So it's meant to enhance a person's current care by focusing on quality of life for both the patient and the family. Okay? So it's begun at the discretion of the physician and the patient at any time, at any stage of the illness, terminal or not. Okay? So who can benefit from palliative care? So it's a resource for anybody living with a serious illness, heart failure, chronic obstructive pulmonary disease, cancer, dementia, Parkinson's. Those are just a few. It can be helpful at any stage and is best provided soon after a person is diagnosed, because it provides support and comfort and helps. So there's no reason to delay palliative care. Okay? In addition to improving quality of life and helping with symptoms, it can help patients understand their choices for medical treatment. Again, in palliative care, the person does not have to give up treatment that might cure their illness. And it can be provided right along with that curative treatment. It could transition to hospice care if the person is likely to die within 6 months. Okay? Or the person could choose, no, I just want to stay on palliative care. That's okay too. Okay? The focus then just changes to comfort. So where does palliative care happen? Okay? It can be provided wherever the patient is being treated for their illness. A lot of times it's provided in the hospital. It can be provided at the doctor's office, in a nursing home, in the patient's own home. Okay. Now, we are really lucky here in our community because St. John Medical Center has developed, they've spent a lot of time and energy and have developed a really good palliative care team. So I would say it's one of their strengths now. They do a good job of making patients aware of palliative care, involving people in that. And most hospitals now across the country have a good palliative care team. I think we've just kind of evolved as a society and realized the importance of quality of life through any illness, particularly prolonged illness. Okay. So who provides this care? Well, there are doctors and nurses who specialize in this field, but your own physician or healthcare provider can also provide some of this care. Okay? And there are many other types of experts who may help, such as social workers, counselors, therapists, nutrition, okay, dietitians, all kinds of things. So that's palliative care. Okay? So it's there, symptom management, comfort, control, or comfort. It can be curative. Okay, it can be while you're receiving curative treatment. So now let's contrast this and compare hospice care. So it too is compassionate comfort care as opposed to curative care. So that's the major difference. Hospice is not curative. Okay, the focus is no longer on cure. It's for people facing a terminal illness with a prognosis of 6 months or less, based on their physician or healthcare provider's estimate, if the disease runs its course as expected. It's what we in the field call the best guess prognosis. Okay. There's nothing about physicians or nurse practitioners or healthcare providers that have any magic crystal ball. We don't know. We truly don't know. But we do know through studies how long this illness, whatever it is, usually lasts in usual situations. Okay. So that's where it's the best guess prognosis. Now, what's hospice care? So it focuses on the care, comfort, and quality of life of a person with a serious illness who is approaching the end of life. Okay. So it's that 6 months window. Okay. And sometimes, it just might not be possible to cure a serious illness, or the patient may choose not to undergo certain treatments or further treatments for the illness. And that's where hospice is designed. Okay, that's what it's designed for. The patient beginning hospice care understands that his or her illness is not responding to medical attempts to cure it or slow it. Like palliative care, hospice provides comprehensive comfort care as well as support for the family. But in hospice, attempts to cure the illness are stopped. The focus is all on comfort and quality of the life remaining. So that's kind of the difference between hospice and palliative, because they overlap so much. It's important for a patient or family to discuss hospice care options with the physician or healthcare provider. Sometimes people don't begin hospice care soon enough to take full advantage of the health that it offers. So, and if I have never, ever heard of anyone that has said, oh, I wish I never chose hospice. That statement just doesn't exist. If anybody's ever heard it, please prove me wrong. What I have heard is, oh, I wish I did this earlier. I wish I got hospice in place earlier on and I didn't wait so long. So that's definitely my encouragement for you that are going into healthcare and others that we are just people that utilize healthcare. Don't wait too long. Okay. But again, goes back to universal truths, right? You've got to accept the universal truth that we all die. Okay. And it's really hard sometimes to accept that truth when it is us, we're facing our own mortality, or it's a loved one in which we're facing their mortality. That is much, much more difficult. So if you start hospice early, it might be able to provide months of meaningful care and quality time with loved ones. Where does hospice care happen and who provides the care? So most hospice care is done in the place that the patient calls home, wherever home may be. This is often the home, okay, as we traditionally think of it, but it could also be a place like a nursing home, a long-term care facility, assisted living, retirement center. Okay. It might also be given in a hospice care center, hospitals, or other facilities. So hospice is really an approach to care. So it is not tied to a specific place. Now, in Longview, because we are so lucky to have a freestanding hospice care facility, okay, we often think, and patients often think, well, going to hospice or going on hospice care means I'm going to go to the hospice facility. That's not the case. Being put on hospice just means you have this lovely support blanket that wraps around you and provides all kinds of care and comfort and support for this journey, okay? For perhaps, the last journey. It brings together a team of people with special skills. So among them, nurses, physicians, social workers, spiritual advisors, trained volunteers. Hospice programs that are throughout the country, that's one of the requirements, is they have to have a volunteer program. That is one difference between palliative care and hospice care as well. So everybody works together with the person who's dying and the caregiver and the family to provide the medical, emotional, and spiritual support that's needed. A member of the hospice team visits regularly, and someone's usually always available by phone 24 hours a day, 7 days a week. Okay, that's usually the nurse. Okay? And when you're a hospice nurse, okay, that's part of your responsibilities is to take call. And that means any hour, any day, someone might call you and say, hey, I have a question, or hey, I have a concern, or this is happening, what do I do? or I think my loved one has died. Okay? And that nurse will go and be there and support that patient and that family at whatever need there is. So they always are addressing everything. I think that that is one of the, there are many, many advantages to hospice, but one of the best things is the family member and the caregiver and the patient have access to somebody 24 hours a day. They're just a phone call away. Okay? So in hospitals, hospice centers, and other facilities, the care is provided by the physicians, et cetera. Okay? But most of the care is done in the home by a family member. Okay? The family member gets help from the hospice care experts, and they're on call 24 hours a day, and they get coaching on how to best provide this care. They also, hospice will provide what's called respite care when the caregivers need a break. And believe me, caregiving is hard work, and they do need a break. Sometimes the break is simply to go to the grocery store, right? But they don't feel comfortable leaving their loved one, or their loved one requires such constant attention. So a volunteer can come in and sit with the patient. That's what respite care provides. Sometimes the family's exhausted and they need a longer respite care. And in that case, in our area, the patient might go to the hospice care center for 3 days or a week just to provide some respite care for the family. Okay? Sometimes another reason that the patient might go to the hospice care center is for symptom control. Sometimes symptoms are just, they just need managed, that we can't quite get everything under control in the home environment, whether it's nausea, whether it's pain, whether it's anxiety. And we bring them into the care center where they can be cared for by a nurse 24 hours a day. And healthcare providers are readily available to consult regarding the patient's needs, and we can get those symptoms under control and then send the patient back to their home. Okay? Most patients, okay, not all, but most patients really want to die at home. And that's what hospice tries to do. Whenever we can, we try to make that happen for them. It's important to remember that stopping treatment aimed at curing an illness does not mean stopping all treatment. Okay, that's another one of those myths. An example is a person with cancer. If the doctor determines that the cancer is not responding to chemotherapy and the patient chooses to enter into hospice care, then the chemotherapy will stop. But other medical care might continue as long as it's helpful. For example, if the patient has high blood pressure, we're not going to just stop treating the high blood pressure because they're on hospice. Okay? We're going to continue to manage that high blood pressure or any other health concerns that they have. Now, the patient, family, and healthcare provider might have a conversation about which medications they want to continue and which medications they choose to discontinue. And that's very valid. There's certain medications that, for example, what we call the statins, the cholesterol lowering medications, great medications for the purpose of helping lower cholesterol, help prevent problems that might arise from high cholesterol in the future. If you're at the end of your life journey, however, continuing on that medication isn't probably as important, right? Because why are we worried about preventing the ramifications of high cholesterol at this point? Okay. So those are conversations to really think about and have with your healthcare providers and your loved ones, okay, to really review the medications, keep everything that is beneficial. And it's a good time to say, you know, that one's probably not needed anymore. Okay. So hospice and palliative care teams, okay, interdisciplinary teams both deliver hospice and palliative care. They address the physical, the emotional, the spiritual, and they address common worries such as loss of independence and the well-being of the family and feeling like a burden. Often patients, that's one of their big things is, oh my gosh, I don't want to burden my family. And now my family has to care for me and I feel like a burden. So that's something we don't ignore. We address with both the family and the patient as well. So hospice versus palliative care eligibility. So hospice eligibility, like I mentioned, it requires that a physician or healthcare provider certifies that the patient has the best guess prognosis of 6 months, less than 6 months to live if the disease follows its usual course. Okay, well, we are all individuals. Nothing about us in our lives and our disease is predictable and usual, right? So there's a whole lot of variance in how quickly or slowly a person progresses through whatever disease they have. Okay. What happens if somebody under hospice care lives longer than 6 months, right? You've heard me say, oh, they've got to have 6 months or less. It's okay. We know that they might live longer than 6 months, and that's all right. We don't just say, sorry, time's up. Okay, we got to find something else. Okay. So as long as the physician continues to certify that, yeah, this still looks like life expectancy is short, they can continue on the hospice program. Sometimes people decide to go off hospice for a while. That's okay too. Okay. So they can bounce on and off of that. It's really a coverage. It's really a program. Okay. So once you elect for hospice, doesn't mean you have to stay hospice. So, and they can return. One of the other things about hospice eligibility, and I think it's on my next slide, but I'll talk about it anyway, is because we're not focusing on cure, right? We are accepting of the universal truth that we all die, and that's not our enemy, right? We're not trying to avoid death at all costs. We're not trying to promote it, but we're not trying to avoid it. One of the other things for a patient to be on hospice is they have to agree, I don't want CPR. I don't want resuscitation efforts. Okay? If I go, I just want to go. Because putting somebody through CPR, okay, and all those resuscitative efforts is wonderful in the right situation. Okay? When you're looking at a terminal illness, that's a whole lot of pain and suffering to inflict on someone. CPR is not kind, okay? It's not gentle. It sometimes breaks bones. Yes, it can save life. And yes, by all means, there are times that it's appropriate, but there are also times when it's not. Okay? And if the patient isn't there yet, if they say, no, I'm not ready. If my heart stops, I definitely want CPR. Then let's go the palliative care route, okay? And until they get to the point where they go, oh yeah, okay, I don't want anything, then we can put them on a hospice program. So it's not an all or nothing, okay? They can make choices. Now, paying for hospice versus palliative care. Hospice costs are paid 100% by Medicare. Okay? Medicaid and private insurance covers most costs. Some insurance also covers it at 100%. That means that everything related to that terminal illness is covered. Your equipment, your prescriptions, your doctor's appointments, like if you need a hospital bed in your home, that's going to be covered under the hospice benefit. You're going to have 24-hour, 7-day-a-week access to care, nursing, social services, chaplain visits, and grief support following death. And the other thing about hospice is you are eligible for hospice regardless of your ability to pay. Okay, so if you have no insurance, you're not on Medicare, not on Medicaid, nothing, but you have a terminal illness and you elect hospice, you will not be denied. Okay, they will cover it. So palliative care costs from office visits to prescription charges can vary based on the insurance. Okay. A lot of insurances cover it really well, some don't. So it's a little bit more spotty as far as how it's going to be covered. So this is kind of a slide that kind of sums up what we've talked about, kind of what's the difference between palliative care and hospice care. And put a few quotes in there. So who can be treated with palliative care? It's anybody with a serious illness. With hospice, It's anybody with a serious illness with, best guess, 6 months or less to live. Will symptoms be relieved? Yes, with palliative care. Yes, with hospice care, as much as possible. I won't say we can always, 100% of the time, take care of all the symptoms. We can't, but we do a pretty good job. Okay? Pain is actively managed in both palliative and hospice care. Okay? Anxiety is addressed, nausea is addressed, respiratory distress is addressed in both of them. Can I continue to receive treatments to cure my illness? Well, you know the answer. Yes in palliative, no in hospice. Will Medicare pay? It depends. For palliative, yes with hospice. Private insurance, same thing, depends for both of them. And then how long will I be cared for? With palliative, it depends, okay, on what care you need and your insurance plan. Hospice, you will be cared for as long as you meet the hospice criteria, okay? If suddenly a miracle happens, and miracles do happen, I will tell you, okay, and the person no longer has that illness or has recovered from that illness, great, they go off of hospice and continue on their way. I know of one case in particular that in the hospice care center with a gentleman who was near death from cancer and don't know what happened, and his cancer went away and he walked out of the care center cancer-free. So life happens, stuff happens, and some of it's unexplainable. Okay? So where will you receive care? You know this, okay? Home, assisted living, nursing home, hospital, that's the same for both, right? Now, the difference with hospice is its focus is going to be on providing care in the home, okay? So both of these, the big message here is both of them, the goal is to improve quality of life. That's the same for either one. Okay, so here's where I listed the eligibility criteria. So this I've already talked about. So next up, we're going to talk about hospice myths. Okay, so dispelling the hospice myths. Okay, and you might have additional ones. Okay. There is a big myth out there that hospice hastens death, or that hospice nurses just kill the patient, or they just purposely overdose them with morphine. I have heard that from a local physician, and I'll tell you, that riled me, okay? As a hospice nurse, I took offense by that statement. Yeah. Yes, we give morphine. Yes, we give morphine liberally. What is our purpose in giving that morphine and giving it liberally? Pain control, comfort. Okay? Morphine is also a great drug to help with somebody in respiratory distress. Okay? So sometimes it can just ease those respirations enough that that person can relax. So yes, it is given for those reasons. Is it ever given to hasten death? Never, never. Okay. Now, that said, I have also found that when you get somebody comfortable, they finally can relax and die. And if you think about it, we have a fight or flight response, right? So if we're in pain, if we're uncomfortable, that initiates our whole sympathetic and parasympathetic response. And what we want to do is fight, get away. If you get them comfortable, that fight or flight response calms down and they can ease out. Their body can go, oh, I don't have to fight this anymore. So it does, you will see it. We get somebody comfortable and then they die. We have not killed them. Okay? We have allowed death to happen by helping that fight or flight reaction get resolved. Yeah. So, and I think that's where this myth comes in. Okay? Because even patients or families will say, well, died after the nurse gave him the morphine. But it wasn't the morphine that did it. Okay? Not directly. Indirectly, we could say it did because it allowed them to exit. Yeah. The other is that, oh, people go to the hospice care center to die. Okay, back to universal truth one. Okay, we all die. Why do they go to the hospice care center? Because they're terminal. Okay, but they don't go there necessarily with the focus on you're going to die. They go there for support through the journey. Yeah. That's where we can focus on quality of life. Okay? And in this case, quality of life and quality of death kind of equate. Okay? We want to make sure that they have as good of a death as they can. Okay? I like to think of it as a journey. Okay? And so we want to make sure that they have the comfort and support around them in that journey. And that journey is as pleasant as we can possibly make it. Okay? I know it seems kind of like an oxymoron to use pleasant and death in the same connection. Yeah. But I have seen, and those that have worked hospice or anywhere in healthcare, I have seen some what I would call beautiful deaths, absolutely beautiful. And as a hospice nurse, I felt privileged to be a guest in that experience, okay? Because it was just something to be treasured. Okay? Often people feel, well, if I stop treatment, I won't get care. Okay, that too is a misnomer. Care, and lots of it, is the focus in hospice. We don't put people in the hospice program, either in the center or at home. We just say, okay, good. Now we can ignore you. It's not that at all. It's the exact opposite. It's more of, now we can focus on you. We can focus on the quality of care and quality of your remaining life. Yeah. Hospice means I've given up. Acceptance is not the same as given up. Okay. Given up implies hopelessness. Okay. Acceptance keeps hope in perspective, right? So it's not that somebody gives up. It means that they've accepted some of the universal truth and maybe accepted that treatment is no longer helping them. In fact, it might be hurting them at this point. Hospice means hopeless. No, not at all. Hospice gives hope, okay, for care, for comfort, for support with all their needs. So I don't see it at all that that's a hopeless sign when somebody chooses hospice. Yeah. Are there any other myths that you guys have heard that you want to throw out there? And let me dispel them. Think about any that you have heard or will hear or that you think about, and to think about why might that not be true. Yeah. Thank you, Jeannie. You know, that's really an important point, okay? Because patients and family often feel that if they choose, I don't want to be resuscitated, or I want to go on a hospice, that means I'm just going to be forgotten about. And that is not it at all. It doesn't change anything as far as still being cared for, and it just changes the focus. Okay? And in some ways, I think it gives it a more special focus. That said, there are nurses, okay, because nurses are first and foremost human. Okay? There are nurses that are more comfortable with death and dying, and there are those that are less comfortable with death and dying. So there are nurses that say, oh, I only like cure. Okay? I'm not good with the death and dying. And I have a patient now that's going through this process and it makes me uncomfortable and I don't like it. Okay. Guess what? If you're a nurse in that situation, you talk to another nurse and you say, can we change patients? Okay. Or you go talk to your charge nurse, because we want to ensure that every patient, no matter what, gets a specialist that cares for them. Just like some nurses are great with cardiac issues. Okay. Some nurses aren't. That's okay. It's not a good or a bad or right or wrong. But if you've got a person with cardiac issues, you want a nurse that knows cardiac. Yes. No, but that's a great myth, right? So no, not at all. Hospice will be covered whether you can pay or not. So let's say your insurance plan only paid up to, I don't know, 10,000 and you're at 11,000. Doesn't matter. You're going to stay on the hospice program. Hospice has a special, that's part of the federal mandate for hospice programs, that they have to accept all patients regardless of ability to pay. Yeah. Pardon me? Not necessarily, not with hospice. Yeah. Yes. Yes. Yes, indeed. And they will look into, the team, okay, will look into how can we make sure that this is covered, whether that's through donations or conversion to Medicare, Medicaid, yes. Yes, yes, yes. Every hospice program across the country does. Now, not every hospice program has a freestanding hospital or a hospice facility like we do. We have one in Longview, there's one in Vancouver. I believe there's one in Portland as well. We're very fortunate in our region, but not all regions do have that. Okay, so stages of grief, right? Yes. Mm-hmm.
And you choose to be at home,
Mm-hmm.
pay out different
Nope.
to you.
Nope.
You could just choose, you want to be in-house at the facility or cared for at home, and the results are the same financially speaking.
Yes, yes, it's all covered the same. So hospice, remember, it's a blanket that wraps around you, okay? How you use that blanket is up to you, right? If you want to use that blanket to cover you head to toe, fine. If you want to use it just to cover your feet, that's okay too. If you want to stay 100% at home the whole time, wonderful. That's what hospice really wants, is it really is focused on home care. If you say, my home doesn't work at all, I need to go into the hospice care center, that's the option as well. So, yes. Okay, so repeat that again for me. Yes. Okay. Ah, okay. That's a great, I get where you're going with that question. That's a great question. So if I've been on hospice, okay, all these expenses have been covered under the hospice benefit, suddenly I get well and walk out of hospice, right? Everything that was related to that point in time is still covered. Okay. Now, once I'm better and I leave the hospice program because I don't need it anymore, then that's where the hospice care benefit will stop. Okay. But just because you get better doesn't mean you have to now pay for all those expenses, because at that time you were under hospice care. Yep. Good question. Good question. So yeah, so if a miracle cure happens, it doesn't mean that then you're going to be burdened with bankruptcy from all the expenses. So, okay, stages of grief. Okay, yes, Armando.
So just one more myth, I think you know where I'm at in my life. I think that the myth might be your next talk, which is that people understand how you get from regular life to what's on that phase. Because it seems like the time leading up to it is fairly confusing, especially right now, hard to find care.
Yes, yes, yes. So Armando's kind of referring to a situation where a loved one may, or someone you know may have a difficult diagnosis, okay, but it's not yet terminal. Okay, so what do you do in that challenge? Yeah, so that's again where palliative care would be the avenue that you would take. And that's also when it's wonderful to involve social workers into the discussion. Okay, how do we negotiate everything that's going on right now? Okay, and until hopefully, if that serious illness gets better, okay, you can still continue palliative care, okay? Or if it worsens and it does look like the prognosis is maybe 6 months or less, that's again where hospice can come in. And anybody can recommend a hospice assessment. Okay, you can call the hospice and say, gosh, I have a family member or loved one or myself, I would like a nurse to come out and assess me to see if I'm eligible for hospice. And you can initiate it. Then the nurse can come out and the nurse will talk to your healthcare provider, get some information about the illness and find out, yes, indeed, 6 months or less or not. Okay. Some physicians are resistant to refer their patients to hospice. That drives me nuts. Okay, that's a pet peeve. I don't know why that is, because hospice provides such a benefit. Now, saying that, I do know where some physicians get this or healthcare get this, and that is because they are trained, particularly older generation physicians are very much trained. Cure, 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 and death is the enemy. Death is a mark against you. Patients aren't supposed to die, we're supposed to cure. Some physicians haven't accepted the universal truth that we all die, okay? And their universal truth is, no, we are gonna fight death at all costs, okay? So, know your own physician or healthcare provider and their attitude towards this, or the loved ones, and don't be afraid to ask them, okay? And if it's not working for you, your right is to get a different healthcare provider involved, okay? So, I am not. That's a wonderful, great discussion on a pulse. Physician orders for life-sustaining treatment. Okay, so that goes along with whether you want CPR or no CPR, or what kind of treatments you want at the end of life or don't want at the end of life. So advanced directive pulse, all those are great. They are a talk in of themselves. Yeah. I believe that that has been a conversation at some point, but it's been quite a while since we've had that. Yeah, that's a great one that affects all of us. So, stages of grief. All right, you may or may not have heard of Elizabeth Kubler-Ross. Okay, she in about 1969 identified 5 stages of grief, along with, I can't remember who the other person was that did this with her. She started with 5, and if you look at the stages now, you will see some research that says 7. Okay, I like 5. 5 fit with me, but I put 7 up here. Okay, so first one's denial, right? Whenever we have a bad event, what's the first thing our little brain does? Deny it. No, that didn't happen. No, I didn't get that diagnosis. No, they've got the wrong person. Okay, next up, we usually get mad about it. Okay. That's just us. That's just humans. Okay, there's usually some anger about it. Next, a lot of times we bargain. We might bargain with our healthcare provider. We might bargain with God. We might bargain with our mother, but we bargain. Okay, please, if you just heal me from this, I'll go to church every Sunday. Whatever the bargain is that you do. Okay. Next comes depression. Yeah, those are overwhelming feelings of sadness. This is normal. This is expected during grief. Okay, this is different than clinical depression. If the depression is prolonged, okay, and it has all those other prolonged symptoms of depression, then they need some clinical help to get through it. But depression is normal in grief, okay, and it doesn't need treatment other than good listening ears. Okay. Now, the last stage for Kubler-Ross is acceptance and hope. Okay. The other 2 that are kind of thrown in under depression is sometimes people, they're going through the depression. Let's think of a breakup in a relationship, right? And you're all depressed, and then you kind of have an upward turn moment where you kind of go, okay, maybe that wasn't all bad, right? And then you start some reconstruction and working through, okay, I can learn from this mistake and I can look towards the future, okay? And then it comes acceptance and hope. Okay. Now, there's whole lots on grief. I really actually like the topic of grief. One of the things I just read about it was that I thought is very helpful when you're talking about grief It's like a fog. It just is a fog that comes down upon you, and nothing is clear. Your sense of time is warped, your sense of duty is warped, your memories get warped, everything. It's because this fog just invades. And how long that fog lasts and how thick that fog is individual for every one of us. Okay, there's no how long it's going to last, can't say. Generally, we say give yourself a year, okay, from a significant event, because it takes us our little bodies and brains that long to process difficult events. Don't make any major decisions, any major changes, anything for a year after a significant loss of any kind. Okay. So those are just some kind of pointers about grief. Okay. So this is kind of the last objective. Okay. And this was that, it's kind of really my goal for you, is that you would develop hope and empowerment about making end-of-life comfort and care decisions. So I don't have a specific subject to put in here on this one. This is just kind of, I'm hopeful that this is what has been achieved through this conversation today, is that you feel more empowered. I put some resources up here for you, okay, realizing there's so many resources out there. If you just Google palliative care, hospice care, a whole list will come up. But these are ones that I think are particularly reputable. National Hospice and Palliative Care Organization, Hospice Foundation of America, Center to Advanced Palliative Care. There's clinical practice guidelines for palliative care, American Cancer Society, National Institute on Aging, UCLA Health, for some reason, had some really great stuff that I really liked. So I put that one on there, as does Healthline. And Healthline will be in a lot of different sites. Okay, they will pull Healthline information into their site. So it's another good one that you can look up and see. So in conclusion, I want to just say, may your life journey be rich in love, joy, peace, and awe. One of the things when I worked hospice is people would say, oh, isn't that horribly depressing and draining? Yes, it was emotionally draining. No, it was not depressing. It was sad. There was a lot of sad times, but there were so many beautiful moments. And I would have to come home after a shift and process my emotions. Yeah. But it did not depress me, because it was such a beautiful time. And I felt, and not always, believe me, some deaths were not as beautiful as others. Okay. Sometimes you have patients fighting the whole way, or families that are dysfunctional, because grief does all kinds of weird things to everybody. Okay. So it's not all lovely and glorious and angels everywhere. Okay. But it is a special time. It's a special time, and it's very, very unique. Okay. And above it all, you have to keep hope alive. Particularly right now in our world with COVID and masks and everything that's crazy, I guess my wish for you is keep hope alive, whatever that hope may mean. And one last thing I also want to mention, hospice is not just for the elderly, okay? Hospice and palliative care are for all ages. The youngest patient that I had that I took care of died at 6 weeks old. So it's all ages. Okay. So keep hope alive. Thank you for being here today and sharing this time with me.
Thank you all for coming today. Thank you all for coming today. We are out of time, so we won't be doing more questions here, but I'm glad that we did get a chance to do some questions earlier on in the session. So thank you, Karen, for joining us. Thank you to our audience, both here and on Zoom, for attending today. Don't come back next week. Please do come back in 2 weeks.